Welcome to Pediatric Case Review. Today's lecture is a comprehensive, case-based review of cystic fibrosis, the most common life-limiting autosomal recessive disorder in many populations. Cystic fibrosis is a multi-system disease, and the general pediatrician plays a central role in early recognition, diagnosis, and coordinated care. We will work through 13 carefully designed clinical cases covering neonatal presentation, physical examination findings, the underlying chloride channel defect, sweat chloride testing, newborn screening, mutation classification, inconclusive diagnoses, pancreatic enzyme replacement, modulator therapy, pulmonary exacerbations, cystic fibrosis-related diabetes, liver disease, and fertility. Let us begin. Question 1. A full-term newborn, now 48 hours old, presents with abdominal distension and failure to pass meconium. An abdominal radiograph shows dilated bowel loops with a soap bubble appearance in the right lower quadrant. There is a family history of cystic fibrosis. Which of the following is the most likely diagnosis? Option A, meconium ileus due to cystic fibrosis. Option B, Hirschsprung disease. Option C, intestinal atresia. Option D, malrotation with volvulus. The correct answer is option A, meconium ileus due to cystic fibrosis. In this condition, thick, inspissated meconium obstructs the distal ileum. It is the earliest manifestation of cystic fibrosis, occurring in roughly 15 to 20% of affected neonates. The relationship is striking. About 80 to 90% of all infants who present with meconium ileus turn out to have cystic fibrosis. The soap bubble sign, also called the Neuhauser sign on the abdominal X-ray, is characteristic. Management depends on severity. Simple cases may resolve with a contrast enema, while complicated cases require surgery. Question 2. A 6-year-old with cystic fibrosis presents for routine follow-up. On examination, the physician notes bilateral nasal obstruction with pale polypoid masses visible on anterior rhinoscopy. There is also enlargement of the fingertips with loss of the normal lavabond angle. Which physical findings are present? Option A, Janeway lesions and allergic rhinitis. Option B, Osler nodes and a nasal foreign body. Option C, digital clubbing and nasal polyps. Option D, paronychia and adenoid hypertrophy. The correct answer is option C, digital clubbing and nasal polyps. Clubbing results from chronic low oxygen levels and chronic inflammation. It is recognized by a lavabond angle greater than 180 degrees and a positive Shamroth window test, and it is present in most cystic fibrosis patients by school age. Nasal polyps are bilateral and recurrent in roughly 10 to 25% of patients, and chronic pansinusitis is nearly universal in cystic fibrosis. Other findings on examination may include crackles, wheezing, hyperinflation of the chest, and rectal prolapse. The core cause underlying all of these is chronic respiratory inflammation together with malnutrition. Question 3. A child is homozygous for the delta F508 mutation, and the parents ask why this mutation causes disease. Which cellular mechanism best describes the mutation? Option A, the chloride channel protein reaches the cell surface but cannot bind adenosine triphosphate. Option B, the chloride channel protein is degraded before reaching the cell membrane due to misfolding. Option C, the gene produces no protein at all due to a premature stop codon. Option D, the channel opens normally but has reduced chloride conductance. The correct answer is option B. The protein is degraded before reaching the cell membrane due to misfolding. The delta F508 mutation is a class 2 mutation, and it is by far the most common cause of cystic fibrosis. The mutation deletes a single phenylalanine amino acid, which causes the cystic fibrosis transmembrane conductance regulator protein to misfold. The cell's quality control system in the endoplasmic reticulum recognizes the misfolded protein and degrades it prematurely before it can ever reach the cell surface. The result is a near complete absence of functional chloride channels at the membrane. Understanding the mutation class is clinically important because it directly guides the choice of modulator therapy. Question 4. A 4-month-old infant with failure to thrive and recurrent respiratory infections undergoes a sweat test using quantitative pilocarpine iontophoresis. The results show a sweat chloride of 72 millimoles per liter on 2 separate samples. What is the interpretation? Option A, diagnostic of cystic fibrosis. Option B, an intermediate or borderline result requiring repeat testing. Option C, a normal result, so cystic fibrosis is excluded. Option D, inconclusive because of the infant's age. The correct answer is option A, Diagnostic of cystic fibrosis. A sweat chloride value of 60 millimoles per liter or higher is diagnostic of cystic fibrosis at any age. This infant's value of 72 millimoles per liter, confirmed on 2 separate samples, is clearly in the diagnostic range. For reference, a value of 29 millimoles per liter or below makes cystic fibrosis unlikely, and the range from 30 to 59 is intermediate and calls for further analysis. Testing should be performed at accredited centers, and an adequate sweat sample must be collected, with minimum quantities of 75 milligrams using gauze or 15 microliters using the macroduct system. Question 5. A 2-week-old infant has a positive newborn screen for cystic fibrosis. The screening algorithm showed an elevated immunoreactive trypsinogen together with one F508 del mutation. What is the next step? Option A, pancreatic enzyme replacement. Option B, referral to a cystic fibrosis center for sweat chloride testing. Option C, carrier status reassurance. Option D, repeat the newborn screen in 1 month. The correct answer is option B, referral to a cystic fibrosis center for sweat chloride testing. All infants with a positive cystic fibrosis screen require prompt referral to a specialized center, ideally within 2 to 4 weeks. The screening algorithm works as follows. An elevated immunoreactive trypsinogen triggers DNA analysis. If 1 or 2 chloride channel gene variants are detected, sweat chloride testing is still required to confirm the diagnosis, because screening alone is not diagnostic. Early diagnosis is valuable because it enables prompt pancreatic enzyme replacement, nutritional support, and infection prevention. Current guidelines favor floating trypsinogen cutoffs and expanded variant panels to improve both equity and sensitivity. Question 6. A 10-year-old with cystic fibrosis is found to have the G551D mutation, and the pediatrician explains that the medication ivacaftor is indicated. Which class of mutation does G551D represent, and why is this medication effective? Option A, Class 2, which corrects protein misfolding. Option B, Class 4, which improves channel conductance. Option C, Class 5, which increases protein quantity. Option D, Class 3, a gating defect in which the medication potentiates channel opening. The correct answer is option D. G551D is a Class 3 gating mutation. In a Class 3 mutation, the chloride channel protein is actually made and does reach the cell surface, but the channel gate fails to open properly. This is fundamentally different from the Class 2 delta F508 mutation, where the protein never